Thank you for that kind introduction, Jennifer, and thanks to the two previous speakers for really exciting presentations. In fact, I'm going to comment on Stuart's presentation here in just a minute, as it inspired me way back in 1986 with a similar type of presentation equal to the innovations you were talking about today. You know, when I've been with Paige now for 6 weeks, I can't tell you how excited I am to be here. I've been working with Paige and the architects and engineers, though, for 30 years, since I moved to Texas in 1992. So it's a long time coming to be able to have the opportunity to build a strategic advisory practice within Paige. And what I want to talk about today is to kind of go the opposite direction that Stuart talked about and bring it right down to the bedside and not talk about the what, but to talk about the how and the why. How do we address the built environment? How do we address and appropriately implement innovation at the bedside? And quite frankly, how do we address innovation in the OR, at the bedside, in the exam room, in the bedroom? We talked about, Ken talked about hospital at home, and you say, well, what's the built environment have to do with a patient's home? There has to be a clinical command center that's managing all the data that's coming from those remote monitors out of that new care venue. So I'm going to talk about, as I said, kind of the how and the why at the bedside and how we approach that through some myths that I've heard over the last 30 years. The first 10 years of my life I spent on an academic medical center clinical path, wanted to be a general and vascular surgeon, went back to business school, and the last 30 as a consultant, always trying to stay as close to the patient and the care team as possible. Now, I wanted to just point out a couple things before we get going. I think we all know this population growth drives everything in healthcare, it drives everything in home building, et cetera, et cetera. But what we've been experiencing the last 200 years that is still unrelenting is an unrelenting demand on our providers, bringing patients to our door. We had about 1 billion people on the globe for 2,000 years. In the last 200, we're now at 8 billion. That is an incredible force that's impacting the supply side of the equation. Our physicians, our nurses, our doctors, our pharmacists, all the caregivers that surround the patient every day. They're stressed out, they're burnt out, and our responsibility right now as designers, and whether it's designers as architects or engineers or consultants or data scientists, et cetera, is to be able to appropriately design the new care model of the future that can address those caregivers that are trying to take care of a patient. This is a simple example just to demonstrate that where we're practicing right now in Texas. Certainly Texas, if you see, would be the west side of Texas would be much lighter. The east side of Texas would be much darker, for we split the density of the population in two across Texas. And what we are experiencing here is exacerbated from many other parts of the country. Now, I want to talk about 6 myths. These are myths that I've kind of heard over the last 30 years, and then talk about what I think is really the reality that we're up against right now, and how the technology can be applied to the built environment, and what the implication is. So I'll start with, don't worry, it's only minor surgery. Now I will tell you, after we just got an inspiring presentation from Stuart, as I said, as far back in 1986, I had a similar experience when I was a medical student. I was a third-year general surgery clerk on my third-year rotation in general surgery, and incredibly excited to see as much as I could about the surgical world. I was in the rounding on my patients at 4:30 in the morning, and I was running out of a room after I just saw a patient and said, don't worry, it's only minor surgery. And that patient turned and said before I got out of the room, young man, not doctor, young man, may I remind you of one thing. There's no such thing as minor surgery, only minor surgeons. And you know you laugh, but I'll tell you it's stayed with me since 1986 to this day. And we always have to come back to that point that nothing is minor from the perspective of a patient. Caregivers and AMCs make the distinction between major and minor. We do that every day, but patients don't make that distinction. All procedures, even phlebotomy, are major to a child and even adults. And we always have to remember minor surgeries can lead to major complications. So, in ending, one thing that I thought was really exciting was to hear from Stuart about the Mighty Center on how they're taking it out of the 39,000 square foot facility. Did I get that right? Yeah. Excuse me, 29? 29,000 square foot, and taking it out into other venues around Houston or the region. One of the implications that we have right now is that we need to be able to train and bring caring environments into our into the care interaction with our patients wherever it's happening to improve safety. And one of those things is distributed simulation centers and training centers for our medical students, residents, and fellows, and continuing education for our faculty and private physicians. Now, this next myth, we've all heard this, I think. It's as simple as point and click. We've heard this from implementation of our computer systems. The electronic medical record is probably the best example, but we've heard this many other times. I will submit to you that the reality is it's as simple as point and click, and click, and click, and click, and click. And again, we laugh, but at the bedside, in the operating room, in the exam room, it's not a laughing matter to those physicians and nurses that are going through that experience. Now, from a design perspective, I'd like to quote Mark Twain, who said, when he had sent a letter to a buddy of his, many of you have probably heard this quote, "Sorry this letter's so long, I didn't have time to write you a short one." Okay, we need to reflect on that I learned at Accenture, I spent about 5 or 6 years with Accenture, primarily with the design of greenfield hospitals. And they drove into us the Accenture delivery methodology. Of course, it's around technology, which was plan, analyze, design, build, test, train, deploy, optimize. And I'll talk about optimize at the end in a little bit. We need to spend the time up front with our design, whether it's the redesign of a clinical operating model that, by the way, has been working for many years for all the clinicians at the bedside. Before we put in a new quote-unquote enabling technology that's going to make everybody's life better, before what they experience is point and click and click and click. The clicks are so prevalent right now that it's emerged as a KPI. It's a key performance indicator in academic medicine. They measure it, they follow it, and they calculate in certain clinical situations, like in this case, an emergency room physician on a 10-hour shift had 4,000 clicks. That's 7 a minute. That's assuming that emergency room physician is just standing in front of the computer for 10 hours. Assume they see the patient for 5 and stand in the computer the other 5. That's 14 clicks. Each of those 14 clicks, they need to read the screen. They need to respond to whatever's happening, whatever the screen is telling them to do. So we need to spend a little time, as I said, up front, and begin with the clinical use case that we're trying to refine and make sure that the solution's not worse than the current state that we're experiencing today. So related to just point and click, there's just plug and play. We've heard this from our vendors as well. It's just plug and play, get up and running, no problem. The reality is, it's just plug and pay and pay and pay and pay and pay. And I think, again, these are just my comments, everybody, so, and what I've observed. we tend to take on the philosophy, vendors, IT leaders, everybody that's around a shiny new technology, that we want to slam it in at the front end, and then, we'll optimize at the back end. Well, the back end is the operating room, or the patient room, or the exam room. Put the clinician and patient there. I would think it'd make more sense to optimize at the beginning. Back to the Accenture delivery methodology: plan, analyze, design, build, test, train, deploy, optimize. Let's move that towards the front end, because it costs money and time to optimize in the clinical environment. I'll give you one example where this has worked really well, this reality, and to address and plan up front. This is public. It's been communicated by Dr. Peggy Duggan, of general surgeon with Tampa General Hospital. But Tampa General Hospital made the decision to move from an open ICU to a closed ICU model with interventionalists only allowed to write orders. Let's get right down to brass tacks. That's what it means. And an open ICU model where private docs, faculty docs, hospitalists, anybody can come in and write orders on the patient. That is a huge cultural shift for physicians, I think, anyway. And so did Tampa General. What they realized, it wasn't just convincing everybody, hey, we're going to move to a intensivist-led model. It took 7 different vendors with unique technologies to be implemented in the new environment to enable the intensivist-led model, in addition to the EICU that they had to have to monitor the patients across the house, which, if you know Tampa General, is a level 1 trauma center and a very, very busy place. 10 different, and this was a distinction that they made. They looked at the options with an enterprise solution that was available versus this best-of-breed solution that they're putting in place right now. One of the most critical elements of the design to successfully implement the intensivist-led model was a refinement and change of the governance structure among the physicians and caregivers. Many times this is overlooked. And quite frankly, the ability and to get on paper who can write orders in the OR and who's not going to be writing orders was just as important as the technology and the change in organizational structure around the command center. Next myth, and I think we've probably all heard this: the educational mission of an academic medical center is cost prohibitive to the economics of a private community hospital. You've heard this from the for-profits for years and years and years. Med students and residents, too expensive, take too long, they get in the way, they're costly, they increase the length of stay. Well, I'll submit to you that more and more private community hospitals are incorporating UME and GME and fellowship programs into their future strategies for many reasons. One is that we've built 30 new medical schools in the country, and all those residents and medical students need a place to go get clinical experience. And so they're getting involved with that as well. Now, one of the things that's most interesting is that we need to understand that the programming of these future clinical spaces cannot assume that there is no need for robust educational space. And this is so prevalent right now. Many of you probably know this. HCA, the largest for-profit health system in the country, is now the largest sponsor of GME in the country, with 1,800 positions in 2022. So they believe that it's critically important to facilitate and have control of their physician pipeline. Then recruiting at the end of someone's residency, they're going to take control of the medical students and residents through the pipeline, because they know where you do your residency is where you stay to practice in general. So it's an economic as well as a clinical decision. Now, another myth, town and gown. Houston, I've been here 30 years, town and gown challenges are ubiquitous. The faculty physicians service the private docs, particularly when they're practicing in the same institution. These challenges are unique to AMCs. And I'll submit to you, town and gown challenges exist, but increasingly in suburban care venues as well, mainly because of the expansion of academic medical centers into the suburbs. But in fact, it's not binary. There are really, if you really look at the dynamics of a physician, there's a preferred professional profile of any one individual physician that falls into one of 7 categories. I mean, think about the physicians that you know that practice among all the institutions. Some physicians prefer only clinical care. If you really ask them when they wake up in the morning, what do they want to do? They only want to take care of patients. Some only want to do research. Others only want to do teaching. They want to be in the medical school. They really are not interested in research or clinical care. That may be a smaller percentage, but they exist. And then there are others, number 4s, 5s, and 6s, that want to do a mix of 2 of the 3. Probably the more typical are clinical care and research is a typical physician in an academic medical center. And then, of course, you have, the triple hits, like Dr. DeBakey, who we saw, that exist as 7s in the middle, that live their life aspiring to equal contribution to all 3 components of the tripartite mission. The implication of this, if you believe this, that this is what their DNA is wired for them, is what's the impact on departmental operations and individual morale of a physician when there's a mismatch between the individual's preferred preference and the department's expectations. Hey, I just want to see patients, but the dean's asking me to write a paper. Okay? As designers, we need to understand those dynamics and the mix of physicians that either exist in the facility or will be a part of the facility that we will be designing in the future. A bottle of water. Need a bottle of water really quick. All right, one more, and this one I want to spend a little time on. I think is really important, and I think it's one of the most exciting aspects of what is upon us in healthcare today. We've heard that, and certainly I've heard it from other partners that are healthcare consultants when we talk about the challenging economics and the situation that exists from the payer groups, et cetera. Thank you so much. The AMC, long-term, is an economically non-viable institutional dinosaur whose lifetime is limited. And I'll submit to you that the reality is, right now, that the ubiquity of data and the emergence of the profession of data science is driving the next great inflection point in the future of medical discovery and clinical breakthroughs by leveraging the use of all of the data that we're beginning to have access to. Basic science data, lab data, claims data, which used to be really all we had access to, real world data, and not just real world data from our EMR, but from our wearables, from medical equipment, from remote monitoring, etc. This is going to allow us to achieve the power of big numbers, and all of us who have taken statistics understand the power of big numbers. It makes claims data even useful from a predictive analytics perspective. So if you believe that, and we're in Houston, data is the new oil. Data is the raw material that we are going to start harvesting, transporting, refining, and turning into any number of products that the refineries over on Galveston Bay are doing right now. We're going to begin doing that with data, and not only to help patients, but we're going to learn how to monetize that data with innovative partnerships that are developing. TMC's Helix Park is an example, Rice's Ion is an example, and there are many, many others. Now, really, in closing, I want to talk about one example of the use of the power of big numbers. Now, this was presented at HIMSS this year. Two companies, a predictive analytics company called Perception Health and Mon Health System in West Virginia, got together, and Perception Health has been able to license access to 38 billion claims. That includes Medicare, Medicaid, commercial, DoD, VA. In those 38 billion claims, that represents 300 million patients. And they can re-identify a patient, and we can talk about this at the cocktail. I barely understand how they do it. They legally and technically can re-identify a patient to get down to the individual level. They use those 300 million patients and those 300 billion claims, no clinical data, just the claims data, to let machine learning run, and in this case, understand what is the predictive value of lung cancer in that population. So they went primary, secondary, and tertiary service areas. They applied these criteria that were generated from machine learning to that population. They found 20,000 patients at high risk for cancer, for lung cancer. Of those 20,000, 8,000 were Mon Health patients. Those Mon Health patients, they reached out to all of those 20,000 by email, text, letter, however they could. And of those 8,000, 811 patients responded and came in for the free screening. Hey, we think that you might be at high risk for lung cancer, come on in. 811 patients came in. 100% of the 811 were diagnosed with lung cancer. And I know I hear the mumbles in the audience. I mumbled for about 3 months until I understood all of this that happened. And as I said, it was presented at HIMSS a couple months ago by Perception Health and Mon Health as well. And I don't know, has anybody, a show of hands, anybody have heard this story yet on the use of big numbers and Mon Health's around lung cancer? Well, I'm happy to talk to anybody about it, but that's just one example. I mean, there was really no awareness on what the next step was after all these patients are coming in. I mean, this is predictive analytics, preventive medicine at scale for a very specific clinical use case. So I'm personally very excited about the opportunity for data and the academic medical center and the collaborative nature to come together to really rewrite the future of medical discovery and treatment with the power of big numbers. So, summary observations in conclusion. As we just heard, I think data is the new oil, and the power of big numbers will drive the next paradigm shift in clinical discovery and health economics. Physician priorities are more complex than town and gown and encompass 7 distinct profiles, and in the design phase we need to understand this specific to any one particular organization. UME and GME clinical experiences will expand into all clinical venues across the care continuum and even into the home and even virtual care. A deep understanding of the clinical use cases always should precede the introduction of any enabling technology. And as we talked about before, let's try to optimize that at the front end, not at the back end. A minimum viable product philosophy is not good enough for a new technology introduced into the clinical environment. As you know, minimal viable product in consumer apps is the standard. In the clinical environment, I will submit to you that is not the standard we should aspire to. No clinical experience or intervention is minor from the perspective of a patient of any age. And then lastly, please keep the patient always and their caregivers at the center of all design. Thank you very much.